Hey everyone, it's me. If you haven't figured it out by now, um, I decided to kind of look further into single-sided deafness in the pediatric population, but specifically looking at cochlear implants as treatments and then the long-term impacts of cochlear implants on these kiddos. So, just a little bit of a review in case we forgot. Some of the binaural hearing advantages we have dichotic hearing, redundancy, head shadow effect, squelch effect, cocktail party effect. So, all of these elements basically come into play and are important for sound localization, speech and noise, and spatial hearing, as we all hopefully know by now. And then the disadvantages of unilateral hearing are speech and language development delays, decreased academic performance, and behavioral problems, most likely due to that decreased performance, and difficulty hearing in noise. So now let's jump into it. I looked at this article by Ardnat if at all. And it was a more recent article, which I really liked. And it looked at the duration and etiology of single sided deafness and what the implications were for cochlear implants. So it kind of gave a little bit of a background. So, what do we know currently about cochlear implants in single sided deafness? We know that specifically for adults, they have shown significant benefit with a cochlear implant. For pediatric populations, that's been more recently introduced, but those kids that have been implanted have also proven similar results to adults. So, therefore, it's important for us to kind of being aware of this, since cochlear implants are not yet approved for single sided deafness by the FDA. And, it is something that we are seeing more. So we all kind of need to do more research about it and put information out there so this is something that we can progress more in our field. And then CIs are generally the only treatment option to help children kind of improve this aspect of binaural hearing. As we know, binaural hearing definitely has a lot more advantages than unilateral hearing does. So, trying to get these kiddos to have the most optimal advantage of binaural hearing as possible. So, the children that were looked at in Ardnat et al.'s study about the etiology and duration, whether or not that matters for cochlear implants, they had children with asymmetric hearing losses, also including SCD. All of these children were examined prior to cochlear implant treatment, of course, via your pure tone audiogram, CT, MRI scans, as we know, to check, the anatomy and integrity of the nerve. They were all underwent an ABR and an ECOG. They also did speech and noise testing to check for the child's localization abilities. So that was done unaided before CI was implanted, and then it was done 12 months post CI. Subjective evaluations of the speech, spatial, and qualities of hearing scale was used and was completed both in the pre and post CI conditions. Children that were old enough to complete these did, but parents also did report on their individual child's. So here is a graphic representation of the demographics of those children in this study who were treated with cochlear implants. So there's about 20 children, which in this, the categories included the duration of deafness, the age at implantation, the onset of deafness, and that etiology that we want to see. So a total of 50 kids with single-sided deafness were evaluated. 24 of those kids had congenital unilateral hearing loss that was diagnosed under the age of 2. 6 had perilingual between the ages of 2 to 4, and then 20 had postlingual hearing loss, so about greater than 4 years old. But as you can see in this table, the children that qualified are the ones that are on this table. So, just kind of look at this and see, we have CMV infections, decent amount of those. We have a couple EVAs, a couple meningitis, couple unknown. So just all things to keep in mind as we've, had our presentations about disorders and syndromes. It's definitely interesting to think about the severity of each of those and how those can impact the child's potential success. So from this study, we know that the most frequent cause of deafness in congenital SSD kiddos was plasia or hypoplasia of the cochlear nerve. And so kids with, cochlear nerve deficiencies are therefore then not recommended as CI candidates, which I'm sure you guys all know why that is. Another etiology was CNV infections that we talked about. And thanks to Kissel, we all have a little bit better of an understanding of what CMV infections are and how it manifests. And then as far as postlingual SSD, the main etiology that was seen was EVAs. So all cochlear implant intervention was done before the age of 4 years old. And then children with acquired deafness generally had better outcomes with their cochlear implants, as shown in the test results. So what was concluded then was that the selection criteria in pediatric populations, whether or not they should get CIs, clearly more emphasis needs to be placed into looking at the etiology per se of why they have this single-sided deafness, the duration and onset, because all of those are factors that can influence the child's predicted potential outcomes with the cochlear implant. However, every child is a case-by-case scenario, so again, that's why it's so important to have such a routine, thorough evaluation pre-CI to determine, what their anatomy is like based on, potential etiologies. So more consideration on, each child as an individual and their specific anticipated results. But again, it's a case-by-case scenario. So just something to keep in mind. So I'm going to propose a question. What are the impacts, do we think, of early cochlear implantation? I'm going to keep talking because it's kind of weird listening to this when there's a big pause. But I'm sure we're all thinking, obviously to enable rehabilitation of these binaural hearing skills to the best of the person's ability. So now we're going to go into cortical plasticity and reorganization. So the earlier we implant, the less cortical reorganization there is in the brain. And I thought that this was something very interesting. We'll go into it a little bit more, but as we know, there is that sensitive period that a lot of people talk about of learning language. So for these kiddos that are born with single-sided deafness, yes, they're still going to learn language and have, the ability to babble and whatnot. However, because one ear is completely out of the mix, it's important to consider implanting these kids in that sensitive period to minimize this cortical reorganization, because the longer and later we wait to implant them, the outcomes that we can expect and we have seen might not be as beneficial as it would be had we implanted them early on. So for the next couple of slides, I'm going to go into a couple of case studies that I found. I wanted to kind of change up the presentation a little bit, and I really liked these case studies because they were fairly recent and they give a better idea of, case-by-case scenarios of how these kids with single-sided deafness and cochlear implants are doing and what was observed. So in this first case study, it is by Dr. Anu Sharma et al. So this was done in 2016. So some background information that was presented in this article. As we know, FDA approval for single-sided deafness cochlear implants is not approved currently in the United States. So for bilaterally deaf kids, we have seen that cochlear implants have been successful in these kids during that sensitive period that we were talking about. And how exactly do we know that? Well, benefits are assessed using electrophysiological results or testing as well as behavioral testing. So that can show cortical development and speech and language outcomes. And they've compared kids who were implanted early on compared to kids implanted later on, and kind of assessed, that there is, yes, in fact, a sensitive period. So that is definitely important things to keep in mind. However, going back to bilaterally deaf kids, especially if those are congenital deafness, there's more evidence showing poor CI outcomes, potentially due to cross-modal reorganization within the brain. So that's when sensory modalities, other sensory modalities are recruiting, other ones to compensate for that deprivation, sorry, having word finding problems and speaking issues today. But deprivation in another area. So if there's lack of auditory input going on, then it's going to be taken over by another sensory area to compensate for that lack of information coming in there. But this idea of cross-modal plasticity in single-sided deafness cases has yet to really been studied. So this is one of kind of the start of all of that, because it's not known whether or not these cross-modal changes, if they are present, can be reversed with cochlear implants, specifically in SSD cases. So Sharma et al. Then looked at the development of cortical neuroplasticity in a child with SSD in both pre and post cochlear implant. So the subject information of this little girl, she was 5 years old. She had a progressive idiopathic hearing loss in the right ear. She had trials with a cross hearing aid and an FM system. And the progression of the hearing loss, because it was eventually progressed to such a severe degree, she was unable to benefit from hearing aids, thus going a cochlear implant route. The FDA denied an approval for a bone-anchored hearing aid. So little more background, her unaided thresholds in the right ear were severe to profound sensory neural hearing loss, and the left ear was completely within normal limits. Her unaided speech for the right ear, SRTs, were 80 dBHL, and the left ear was 5. So at 9 years old, she received a cochlear implant. So in this study, they did cortical evoked potentials, which is the CAEP. They did cortical visual evoked potentials, which is the CVEP. And they did cortical somatosensory evoked potentials, which is the CSSEP. So those were all recorded from the child's scalp using one of those electrode nets. So the CAEPs, the cortical evoked potentials, in the pre-CI condition, the BA stimulus was presented to the left ear at 65 and to the right ear at 100 through insert earphones. Then in the post-CI condition, the same stimulus was presented. This time, and the right ear was presented at 65, and it was done through sound field at 45 degrees to the left. The CI was turned off when it was presented to the left, and then when they presented to the right, there was a deeply inserted earplug and a muff on top of the left ear to make sure that that left ear had no chances of hearing that stimulus. Then for the cortical visual evoked potentials, the CVEPs, There was a high contrast sinusoid that was presented in a circle, like a circular or star pattern, or in a modulated grate. And so this was recording the child's perception of motion and shape change. For the somatosensory evoked potentials, the CSSEPs, tones were presented with a bone oscillator using a steady state noise through a speaker to mask the bone audibility. So just that feeling, that somatosensory. So as far as the behavioral recordings went, they were done 33 months post-cochlear implant. So speech and quiet was assessed using the AZ BIOS sentences, and it was a cable-directed, connected directly to this girl's cochlear implant. Then noise was presented through each loudspeaker. So then the sentences that were presented were in noise, which was condition 1. So the noise was on the side with the cochlear implant with the processor turned off. And so then it was testing the function within the left ear. So then condition 2 was still sentences and noise, but the cochlear implant was turned on, and then the signal was directed at the cochlear implant. So to see the difference between those ears. So here's the first figure. The next couple of slides will be a bunch of graphs that I'll try to do my best at explaining to everybody. So the graph A that you can see, the normal hearing left ear, this was the cortical evoked potentials, and it shows a clear P1, N1, and P2 response. You can see the morphology looks pretty nice, and the peak latencies that were measured were all within normal range for this little girl's age. Then figure B is the right ear, so the ear that was implanted. You can kind of see, it's a little challenging, but you kind of have to look at it, but there is a delayed response of the P1 component with abnormal morphology, so it's not as smooth as in the normal hearing ear, and that P1 response dominates the recording. So you can't, there's an absence of that N1 and P2 response, which through research and whatnot suggests that there's an immature development of the central auditory pathways on that side. So this diagram, you can see some scans of the brain, kind of where the P1, N1, P2, is being recorded from. So the colors in those gray kind of brain scans depict the current density of those 3 cortical evoked potential components. So this is for the left ear, the normal ear. So the components are activated in the contralateral auditory areas, so specifically in the superior and medial temporal gyrus, the inferior frontal gyrus, and the frontal gyrus and insula. So the activation of those contralateral temporal cortex suggests that the activation of the right cortex was significantly weaker, and the current density on that right side was not apparent. So now you can kind of see, you have your graphical representation of the CAEP, but then the graphs with the colors will show you this is what it looks like, or what it should look like. And in the right side, the side that was implanted, the current density was not as well visualized as it is on the normal hearing side. So sorry that this graph is on its side. It was too big to put right side up, and I wanted to keep it nice and big so everybody had a better, easier time seeing it. So you're going to have to tilt your head a little bit. Apologies. This graph shows the developmental progression of the right ear that was implanted for both pre and post cochlear implant conditions. So you have your pre-CI, 3 months, 8 months, and 14 months post-CI. So all you can see, so you can see in the pre-CI condition, you have your P1 at the top, which is the one that dominates the response and kind of a more poor morphology. If you jump down to 8 months post-cochlear implant, the morphology of that response does in fact change a little bit. It smooths out a little bit more, and you can start to see the N1 and P2 complexes now are able to actually be recorded and visualized. So kind of keep that in mind, now getting used to this auditory stimulation, there's more to that cortex that was missing all of this information. And then, as you can see, by 14 months post-CI, it was found when compared to the left ear and other kids who had normal hearing that age-appropriate age-appropriate cortical evoked potentials were then observed for this girl on the right ear with single-sided deafness. So by 14 months, post-cochlear implant, auditory stimulation to that side, she had cortical evoked potentials that were more clearly observed than before and more in line with her peers. So the top corner, figure 4, you can see both pre and post cochlear implant conditions. So this is showing changes in current density when the single-sided right ear is being presented to. So in the post-cochlear implant image, which is, you can see on the top, it says post-CI, you can see more robust contralateral activation of only the temporal areas, which suggests more of a typical auditory pathway development. So that's pretty cool. And then there's a decrease of frontal activation, which suggests a decrease in listening effort, Then the next diagram over on the other side, this is depicting visual stimulation, and that's shown in the upper portion of the figure. So P2, both P2 conditions where it says pre-CI and post-CI, that's the cortical visually evoked potentials. So post-cochlear implant was shown activated higher order of visual areas. So, once that cochlear implant did go on and a couple months post implant, there was more activation of those visual areas, which was more consistent when compared with typical processing of visual stimuli to peers. So the response pattern then in this, for these cortical visually evoked potentials, suggests that the dominant activation occurs in visual processing regions, which can suggest or be consistent with a slight reversal of visual cross-modal plasticity. However, it is important to note that there still are some auditory regions that are being recruited. It's just less than what it was, or it's just not as many as it was before. So this is another figure, clearly, and A, B, and C were different kind of tests and conditions that they did with this little girl. So figure A, where it says normal hearing on the bottom, this is when the speech and quiet test was completed using AZ Bio. So you see that solid bar, that's the mean score, and then the patient is represented by the dark black circle. So she is compared to people with normal hearing in this diagram of speech and quiet using AZ Bio, and she's performing well above the mean with that cochlear implant. Section B in the middle here, this is the percent improved in speech understanding in complex environments with noise. So the white bars that you see are adults who were implanted with cochlear implants who had single-sided deafness, And then the gray bar is our patient. So she's, performing pretty well in line with when compared to adults who had cochlear implants. And then figure C all the way on the right is about is when sound localization was tested with a wideband stimulus. So the dotted line at 10, it's kind of a blurry graph, apologize for that, but the dotted line is the 95th percentile, and then the patient again is represented by the dark black circle. So she's definitely performing well with her cochlear implant, which is really awesome to see, and that's something that it's nice for us to see a little more data and research on that. So what was concluded from this article was that there is a very high degree of neuroplasticity that was visualized in the auditory cortex after implantation at 9 years old. It's possible that the progressive aspect of her hearing loss may have restricted some deterioration of the central auditory pathways. And then cochlear implants in single-sided deafness may reverse cross-modal reorganization from other modalities, as we saw with the visual evoked potentials. And this was seen in temporal areas for somatosensory processing at about 27 months post-CI. And then the reversal of visual cross-modal reorganization may take longer due to the functional role of vision in everyday life. So, something to keep in mind. But what was even more clear from this study is that clearly there needs more research needs to be done, especially using more subjects. As this was a case study done of one, it showed great results, but there needs to be more research, and we need to have more things like this past study, to see, more with more kids. Is this possible? So the next case study is Silva et al., and this is more recent, which I thought was really cool, and that's from 2017. So let's go ahead and jump into that. So some background information on this article that this article provided was that auditory stimulation during childhood allows for central auditory nervous system, the CANs, to undergo neuronal plasticity, which helps facilitate auditory detection, discrimination, recognition, and comprehension. Behavioral, auditory, and language responses post-cochlear implant are not always immediate and precise. It takes time, and it's influenced by a significant amount of variables. And then cochlear implant benefit is determined by the integrity of those central auditory pathways in Herschel's gyrus. And second, auditory areas, so lateral to the lateral surface of the temporal lobe, as well as Wernicke's area, and then the post-superior part of the first temporal gyrus. So again, back to that sensitive period, it was found, and we probably already know, that the sensitive period is up to about 3 years old, and that's really optimal time to start this process of rehabilitation. And anything after 3, abnormalities in development of synaptic plasticity can happen, which can create abnormal neuronal connectivity. It can cause disintegration and functional maturity of the auditory cortical areas, and impaired connection between primary and secondary auditory areas, which then develop non-auditory functions such as visual and somatosensory functions. So that impaired connection between those primary and secondary areas, it was shown, that when the visual and somatosensory functions take over, that is an example of that cross-modal plasticity that we were talking about in that previous case study. So in this article, they used long latency auditory evoked potentials, LLAEPs, to evaluate the cochlear implant benefits, which then were correlated to behavioral audiograms. So this measures, this LLAEP measures the degree of development and plasticity limits of the central auditory pathways by looking at morphology and that P1 latency change, which is generated by that electrical activity in the primary auditory cortex. So their thought was using these LLAEPs to monitor that cortical maturation of kids implanted with cochlear implants through electrophysiological and auditory and speech skills. So the subject information in this article, there were 30 children, both males and females. The maximum age of participants was 5. And so then kids with cochlear implants, it was kids with cochlear implants and kids with normal hearing, the two groups. The kids with cochlear implants were deaf for between the months for about 6 to 42 months. They were all, for the most part, profound bilateral prelingual, but they were unilaterally implanted. So this is a little different because they don't have a normal hearing ear, but kind of take it with a little bit of a grain of salt. They were getting regular speech therapy, and there were no additional neuro or cognitive impairments for either groups. So in the kids with cochlear implants, they looked at the auditory and speech skills, and those were assessed using ITMAs and Muse questionnaires. So the mean values, you can see the first section is for the ITMAs, and then the second is for the Muse. The black bars represent the mean. So in the first evaluation using the ITMAs, the mean value was about 58%. And then in the second evaluation, it jumped up to 79.8%. Then for the Muse, it went from the first evaluation, it went from 42.8% to a 59.2% at that second evaluation. So significant differences can be seen between those first and second evaluations, possibly suggesting that the longer activation time of cochlear implants, the better the behavioral outcomes were when reported by the parents. So that's kind of cool. And then they used the Glenn-Donald Auditory Screening Procedure Protocol, the GASP, and that showed auditory skills achieved 9 months post-cochlear implant. So they looked at detection, discrimination, and comprehension. Detection was the 9 months post-cochlear implant. Detection was found in 53.5% of these kiddos. Discrimination was found in 40% of the cases. However, comprehension was only found in 6%. But again, this is 9 months post-cochlear implant, so I think that's pretty good, for what we're seeing. Then the electrophys evaluation. You can see on the top is the first evaluation, and the bottom is the second evaluation. And so you can see that P1 component was seen in both groups of participants. So kids with cochlear implants, the tracings were more defined, so better morphology in that 9 months post-CI due to more of that auditory experience that they were now being exposed to. The LLAEP results over time did show that there was a decrease in that P1 latency for both kids with CIs and kids with normal hearing. So that P1 latency reduction, even though it was seen in both groups of kids, the latency reduction was more evident in those kids with cochlear implants, suggesting that 9 months post cochlear implant, having that auditory experience, latency values significantly changed. But a big important thing to keep in mind, there was a significant difference in that P1 latency value when comparing both groups. So when comparing kids with normal hearing to kids with cochlear implants, even 9 months, after auditory experience, it's still their P1 latencies was still not in line with kids of normal hearing. So suggesting that there was still not as sufficient, it wasn't sufficient enough to achieve the same latency values. But again, 9 months, it would be interesting to look at then, later, 21 months or 30 plus months to see if at all that is achievable. So here we have a comparison of the auditory, speech, and electrophys measures in kids with cochlear implants. So this is a comparison of the P1 latency component of the LLAEP with the responses of both auditory and speech skills in these kids with cochlear that were implanted. So what we're seeing in this scatter plot is a longitudinal correlation between the electrophys measures and the questionnaires that were completed. So a correlation between, there was the first graph A is for the ITMAs, and then graph B was for the MUs. So for both of the cases, the correlation was negative, suggesting an improved ITMAs score and MUs score with a reduction in that P1 latency. So from this study, what was concluded was that after 9 months post-cochlear implant, parents were able to perceive gradual changes in their child's auditory skills measured by the questionnaires. Development of more complex auditory skills was seen. However, a longer experience with cochlear implants is needed to see if that development can continue improving. Maturation of the central auditory pathway is dependent on intrinsic factors, which becomes dependent on that individual, as well as the extrinsic factors relating to the exposure and what's in their environment. The LLAPs showed notable CANS maturation in the amount of neurons that were responding to the sound. Morphological and functional changes of those, reduced P1 latency components suggest that the anatomical and physiological changes, there were anatomical and physiological changes, like I said, which impact the P1 latency. Children with normal hearing also experienced a P1 latency decrease. However, kids with cochlear implants experienced a greater decrease. Those LLAPs were shown to be a good longitudinal tool to monitor the maturation of the central auditory pathway. There was a correlation between those electrophys results and the response to auditory skills and on those parent questionnaires. And then that development varies for a child, and results are gradual over the course of that auditory experience that they are being exposed to. So in conclusion, cochlear implants allow for auditory stimulation, enabling a gradual maturation of the central auditory nervous system as observed through these LLAEP tracings, and enables auditory and language skills through parent observation. So these evoked potentials proved in this case to be a good clinical tool in monitoring that process of cochlear implant benefit, reflecting that plasticity and functionality of the central auditory nervous system. So definitely interesting to keep in mind. And yeah. So thanks everyone for watching. I know some of those case studies kind of were confusing and graphs were a little challenging for me to understand and explain. So I've attached my references at the back if anybody wants to read those articles. Have a good rest of your day or night or whatever it may be for you. Bye guys!